Hi, everyone. Thank you so much for joining us. First, I just want to say Happy Veterans Day to all our service members and veterans. We thank you for your service and your sacrifice. My name is Carmen David. I am an aortic dissection survivor with no family history or knowledge of aortic disease prior, and it happened 22 hours after I delivered. And my co-host here, she can introduce herself real quickly. Diana.
Hi, I'm Diana. I have Loeys-Dietz syndrome, which I found out after I dissected, which was also 3 days after I gave birth to my daughter 10 years ago in September.
Thank you. Well, today, guys, we're going to be kind of covering a lot of different topics. We're just going to kind of have a relaxed chat here with our expert and questions really around family planning, whether you are trying to conceive, are already pregnant, or in the postpartum period as well. We have a couple of topics regarding research, even and hormone therapy, breastfeeding that we would like to touch on as well. So hopefully you can stick around and there's a topic that's pertains to you or is interesting to you or you have a question about. And feel free to go ahead and ask questions within the chat, because at the end we'll go ahead and get to some online questions. If there isn't any, then we'll just wrap up from there. Tonight we have our expert is Dr. Stacy Fisher. She's a cardiologist in Baltimore, Maryland, especially in the care of adult congenital heart disease, pregnancy-related heart disease, and congenital heart pulmonary hypertension. She is the Associate Director of Adult Congenital Heart Disease Center at Johns Hopkins Heart and Vascular Institute and an Associate Professor of Medicine at Johns Hopkins University School of Medicine. So welcome, Dr. Fisher.
Thank you so much. It's an honor to be here.
Thank you. We're always so grateful to have compassionate doctors come in and take the time to speak with us, because we always have a lot of questions. And so we appreciate you answering those for our community. We've had some other physicians on here. We've had a cardiovascular surgeon, an OBGYN, another cardiologist. So we just really appreciate all your expertise and time for us. So thanks. So first off, I guess, so for our ladies to kind of understand, of course, this is basically geared to that group of the pregnancy in aortic disease or postpartum with aortic disease. So can you start off by telling us a little bit about some patients that maybe come to see you that are relatable to our cases?
Sure. So I see a lot of genetic cardiac disease and a lot of aortic disease. So I have these conversations regularly with people, and people make decisions that are very personal related to pregnancy and aortic disease. Certainly in aortic disease, there's a lot of different conversations that occur. One of them is preconceptual counseling. I'm thinking of a pregnancy, what actually is my risk? And that can be different for different people. So if somebody has already dissected, usually there's some residual dissection, there is fragile tissue, and there can be a lot of variation in how the blood flow is to the rest of the body, including the spine, the legs, and the uterus, and the fetal support. So there's variability in the risk and the likelihood of carrying a full-term gestation. And that we like people to actually meet with their doctors, go through what is their risk, why did they have a dissection, do they have a connective tissue problem, do they have a connective tissue problem that may affect the uterine support, the abdominal muscles, or is it something that can also be associated with other aneurysms like brain aneurysms? Because during pregnancy, there's a lot of challenges. So the blood volume, the cardiac output are much higher. The body actually has to support 40 to 50% more blood volume during the high peak volume of pregnancy. And there's a lot of relaxation of the smooth muscle in the vessels due to hormones like progesterone, which can make the wall integrity weaker. So the risk during pregnancy of increasing an aneurysm or dissection is high. So if you know that you have aneurysm or dissection already, it's really important to establish this high-risk discussion and team and make sure that this is something that you really want to risk. There also are options such as surrogacy, donor egg and sperm options, genetic screening of your own eggs, so that even if you want to carry the pregnancy, if you have something like Marfan's or TGF-beta or ACT2, if you have an abnormal gene, you could actually screen the eggs or the embryo for that gene and then decide whether or not you're going to go kind of natural and have a pregnancy and take a chance, or whether you're going to screen out the gene associated with more fragile vessels for the future, so that if your child doesn't have the gene, their children also won't have the gene. So that is now available if you know what the gene is. So the first conversation, I think, just to answer your question, is really preconceptual counseling. The next conversation would be somebody that is already pregnant, that may have higher risk or may have known disease and need management during pregnancy. And that, again, we like to establish care. We like to understand the individual risk of the particular woman and establish a team for that care. So that team may be OB and vascular, genetics. We may need OB anesthesia's input and support. We may need special lines or monitoring during labor and delivery. Everybody in this group really should have a home blood pressure cuff anyway, but during pregnancy, there's so many fluctuations in blood pressure, risk of preeclampsia. If there's abnormal flow to the placenta, there can be much higher risk of preeclampsia, which can lead to very high blood pressures, which can then affect the rest of the vessels. So having a home cuff is critical. And then conversations about breastfeeding and about modes of delivery and medications that may be safe or unsafe in delivery. So there's a lot to it. And I think having these conversations leads to a much better experience, better personal decisions, better understanding of the family for those decisions. And then one thing that I've really found is even if the woman understands what's going on, her partner may not. So making sure that the family is also educated as to the risks, what to look for, how to help, what things matter, whether it's a low salt diet and what you show up with as a gift, that can actually make a big difference. So educating and dealing with family expectations is important.
Yeah, I guess, of all the questions and stuff we thought of, I didn't really think about the aspect of the partner, because I think we're always so concerned about what's going to happen with us directly and with the baby. So I'm glad that you mentioned that. I know that our group has evolved so much. Diana, do you want to explain maybe a little bit about how our group has evolved and all of those topics that she touched on really are, they're just tons of questions.
Yeah, I mean, when we first started the group and when we first met, Carmen and I, we were strictly speaking about aortic dissection during or post-pregnancy. And we've had, I would want to say 8 to 10 women join the group just in the last couple months alone that are talking about not even close to dissecting, but just any kind of cardiac issue they have, anything that runs in their family, things that maybe they haven't known and found out later there might be an aortic issue and they're thinking about getting pregnant. It just really went from aortic dissection specifically to pretty much any cardiac issue that they can think of, and then them wanting families. Some of them have already had children and want more post surgery or post knowledge. Some of them haven't started families yet and aren't sure if they want to at all.
Yeah.
So preconceptual counseling is, becoming a very standard option that I would encourage everybody to take if you have concern about your aorta or your family history of aortic disease. because again, getting the genetics evaluated ahead of a pregnancy can make a very big difference in the way that you're cared for, the surveillance, the timing and mode of delivery, which can definitely protect the aorta. The other thing that we didn't mention is if the man is the one who actually has aortic disease or dissection, you still want to look at the genetics and the fetal outcomes, and what can we do to make things safer for the child. So it's very important even then to have the preconceptual counseling. So some of the genes we're talking about have a 50-50 chance of passing down. Some are more recessive, where it's maybe 5 or 10% chance. So it's a big difference, and it's a big difference in risk. And we all have our levels of risk that we have for ourselves or our family. And when you're talking about a family decision, it's really important that you put your level of risk in line with the level of risk that your family is expecting and willing to take, or at least aware of. So I think that makes a much better experience and outcome if everybody's on the same page. So coming in and saying, hey, I have a family member that had a dissection. It was my brother or sister, and I'm concerned, and I'm thinking about having a pregnancy. What can I do to be evaluated now to lower my risk? How can I tell what my risk in pregnancy is? And we also have a population, which is your original population of, I had an aortic dissection, I'm thinking of another pregnancy. And we know that's very high risk, right? And we're seeing more and more people decide to go ahead with these high risk scenarios, which obviously affects the whole medical community and trying to have great outcomes. So we are partnered. We will accept whatever decision somebody makes, but it's so much better when everybody's informed and you have support.
Yeah, I love that you say so much about the genetic research and about your whole family dynamic being involved in it, because I know we have a lot of questions regarding, again, the family planning pre-conception, like maybe they've never even had a child yet. And then post-dissection, I myself wanted to have another and they immediately told me no. So there's a lot of questions because, like, one, we don't really have enough research or scientific evidence out there to really guide us. And I know that there's a lot of individuals working on that, which is fantastic because, without us participating in those things, we can't really learn and move forward for the next affected folks, but then sometimes the doctor advice isn't always consistent either. And so there's some mixed messages that also doesn't really help weigh the decision for a patient sometimes. And then sometimes you're torn because, like you said, the risk can be high. And so if they're already telling you no, then you feel torn because, of course, you may really desire to have a baby or another baby, and then yet you're listening to the advice of like not, and then you just don't really know what to do. And then if there's not enough scientific evidence, then you're like, well, maybe it could work, and then you might be more willing to have the risk, but like you said, everybody's different, but then you're worried and conflicted.
Right. And again, part of it is understanding what you actually have, which again, for example, what the two of you have, what you're left with may be very different from one another. Somebody may have a complete repair. They might have had a hypertensive emergency and dissection, had the segment of aorta replaced and not have any residual tear, and have really perfect blood pressure control. And their risk is going to be lower than somebody who has a connective tissue problem, also has other risks with pregnancies such as uterine prolapse or placental issues, connective tissue weakness that can affect other parts of the pregnancy. So the risk can be quite different from one person to another. And again, what is the risk when the father has the issues? So it's a conversation worth personalizing, especially in the type of data that we have available now. And I do think these larger databases are really important. And if you are willing and can participate in some of the databases, it makes all the difference in understanding what to do in the future. You know, if you had data from 100,000 women that had gone through what you've been through, which we certainly do not have, you know, could we give you numbers that have more meaning? You know, your risk in pregnancy is X%, and you can make a decision based on your own risk algorithm, right? And set up your providers with people that you're comfortable with, that are on the same page as you, that are willing to support you no matter what. And that's a big part of your pregnancy team, is they are your support team, right? So you need to have them so that if, you know, if the decision isn't working out the way you wanted it to, you can have frank conversations, you can make decisions that save your life in a way that you're comfortable with.
So is the first step then, you think, I guess if you've already, I guess in most of these cases, they're already going to have survived it or know of a family history or been found to have, say, an aneurysm. So then no matter any of those cases, the first step would be to go to a genetic counselor. I mean, how do you, I know, Diana, right? As in a lot of the first question is, well, what do we do now? Like, how do we even get started, right?
I think the genetic counselor
I think
is
it's more to have the conversation with your vascular and cardiovascular team that are monitoring your aorta. You know, what would my risk be? And to meet with maternal fetal medicine, which is the high risk OB doctors.
So start with your cardiologist who maybe diagnosed it or treated you, and then ask them for a maternal fetal medicine physician.
Right, that they can work with, so that if you decided to have a pregnancy, then your team is together.
Okay, so then
Right.
I guess
And
do
you
generally
do
your,
a preconceptual counseling meeting.
oh yeah, oh, go ahead, Diana, too.
I was going to say, speaking of connective tissue disorders, one thing I found more difficult was finding doctors, especially my husband's military still, and we've moved from Florida to Utah, and finding doctors that are aware of your connective tissue disorder. So when we speak about maternal medicine, and if somebody has Marfan's or vascular EDS, or in my case, Loeys-Dietz, especially since Loeys-Dietz was just founded in 2005, there weren't a lot of choices. So if there was a database somewhere where people could find other cardiologists, vascular surgeons, and fetal doctors that are aware, at least, or done any kind of research with connective tissue disorders, would be great to have too.
Yeah. Yeah, I mean, for example, there's an Adult Congenital Heart Association that has a travel directory that you can actually look up their travel directory, and they have the centers of excellence that are vetted and the providers listed. That may be a good thing for Aortic Hope, actually.
Yeah,
but
I'm writing that down so I can.
And a lot of it is kind of self-directed or self-proclaimed. So getting reviews from patients, getting reviews from other physicians would be really important in vetting those places and people. But starting with the people that have been working with you is going to be really important. And then there's a different group of people who are diagnosed during pregnancy, because during pregnancy is the time that a lot of people get their first real medical care. So many people, don't go for regular medical care, show up, maybe they have really classic Marfan's features and complications of that, but they've never thought anything of it. They just kind of power through their symptoms. And in pregnancy, they're diagnosed. So it can be really important to build that team at any point that it comes up, but the earlier, the better. So if there's preconceptual counseling available, that's important. But once someone's pregnant, we're going to obviously take what we can and work with it, right? So we always look at what the definition of an aneurysm was. Was it genetic, hypertensive, traumatic? We don't know, but it's really important to look at that and kind of what is the perfusion to the child, what is the perfusion to the mom, so that we can make sure that both have the best options. There are procedures that can be done to optimize care even during pregnancy, but the risks are higher. And then if somebody's having symptoms that raise concern in pregnancy, like chest pain radiating to the back, fainting spells, palpitations, heart racing, breathing problems, it's really worth at the minimum getting an echo. So the echo is a mainstay of evaluation where you can actually at least see the heart, make sure there's not fluid around the heart, look at the aorta, make sure that at least the parts you can see are safe, and that's all ultrasound. So the echo would really be during pregnancy, probably the first evaluation. Now, if you're having discomfort that's persistent, especially if you do have a family history or history, you want to get to an ER and you want to demand a CAT scan. So we used to be afraid of any radiation in pregnancy, but the radiation tests have gotten to be less and less radiation. So the times you do not want to avoid a CAT scan is if there's concern for blood clot to the lungs or aortic disease. And then it's really important to just do it. So they shield the belly with lead so that you have a lead apron, and do the CAT scan with the least radiation that can be done and get the information. I heard someone recently call it the zone of truth, or the cone of truth. So, and it really is a mainstay in understanding, are you okay? In pregnancy, you can use the IV contrast dye with CAT scan. We don't use the gadolinium dye with the MR. We can use the MRI without the gadolinium dye, but we are a little bit limited in the ways we try to evaluate people, and we really try to take a minute and be very cerebral about what do you really need, what is our suspicion, what is the likelihood. You know, usually the history and physical will be very thorough to try to figure out, do you really need this? But again, say you have Marfan syndrome and you have an aneurysm that's being followed, and you have a new intense chest pain, you cannot leave an emergency room without either getting a transesophageal echo or a CAT scan to look at your aorta and make sure you're okay, because the risk is just too high. Yeah. And you do want to advocate for your friends or colleagues or counterparts through here and say, I have to have this testing. I know I must have this testing. I know I'm feeling something. And you must advocate for yourself, especially if you're traveling somewhere where the level of, the level of exposure to this type of disease is small.
Yeah. Well, we can both attest to having to advocate for ourselves, and you're, you're saying to make sure to get checked out. I know after both of us have said that to the aortic community, in general, because I know for myself, I was having chest pain under my left breast for a month prior. And like, we'll never know if that was a symptom, a sign, or something. I mean, they didn't think there was an aneurysm there prior, that it was just a spontaneous dissection, I guess, just based off the CT that they ultimately did when it happened, on emergency. But,
right, but it could have started with a little tear that then extended.
Maybe because I remember always trying to like hold my chest, like, something was wrong, and they just kept on thinking it was probably heartburn or something. And that's the thing, it can present in so many different ways that sometimes, especially in pregnancy, you yourself can tend to blow it off like it's got to be something else, or a physician can also still do that. So it is so important to advocate for your own care when you feel like something is really off.
Yeah, I was just talking about that myself too, because when I was pregnant with my second child, and I was already, because of my age, I was 38 at the time, and then they found that the cord was wrapped, and the physician just kind of shrugged it off and said, "Listen, I've delivered hundreds of babies with the cord wrapped. It's fine. This happens all the time." And the following week, when I went in for my weekly update, I had said, I get it. You think it's fine, but I'm not feeling fine. I feel like there's something wrong. And if they would have sent me home, I could have dissected. There could have been a cord accident. There could have been so many other things that happened if I didn't listen to my body and if I didn't
Yeah.
advocate for myself.
Yeah.
Yeah,
And
the
you know,
management's
Dr.
very
Fisher, I was going to ask you too. So what would you advise to somebody who is in that scenario where they don't really know what to do yet? I know we've had some ladies that are, you know, maybe they found out they had aortic disease, you know, an aneurysm or something, and they're already pregnant, and now they're worried that their stress level and anxiety is going to make something worse. Like, how do you guide your patients on easing that anxiety, that, you know, creating a team that you're going to be, you know, just kind of putting them at ease?
Yeah, so that's exactly the right thing to do, is create a team to put them at ease. So and also to make sure that they should be at ease, right? To do screening regularly, so some sort of evaluation of the aneurysm at least every trimester.
Okay.
Things like controlling the blood pressure. So there's also a lot of hesitation to use medications during pregnancy, but it's actually really important to use medications that are safe for the mom and the baby as needed. So one thing is controlling the blood pressure. We use a lot of beta blockers during pregnancy. So there are some risks of beta blockers. The risks are small though. There's no risk of malformation of the fetus from the beta blocker. The risk is smaller fetal growth that can be monitored. So, so that's actually really important. And the beta blockers really decrease the wall stress on the aorta, so they can take some of the tension off of the aorta. So medications are important. We do not use in the first trimester things like ACE inhibitors, angiotensin receptor blockers. We do use certain calcium channel blockers like amlodipine for blood pressure. We use other blood pressure medicines like methyl-dopa. But it's very important to regularly monitor blood pressure to make sure the blood pressure is well controlled. And also, an escalating blood pressure can be a sign of distress, like preeclampsia. So preeclampsia in a lot of ways happens if you have poor placental perfusion, that it can cause distress, and that can make the maternal blood pressure increase. So it's actually really important to look at that as a sign of fetal distress or poor perfusion to the placenta, which is the fetal blood supply. So it's important that we look at that. We have started in people who've had preeclampsia in the past, or who even have advanced maternal age without aortic disease, using a baby aspirin, an 81 milligram aspirin starting at 12 weeks of gestation. And the data for using aspirin has been very powerful in lowering the risk of preeclampsia or recurrent preeclampsia.
Okay.
So
I'm glad you mentioned that, because that was actually a question that somebody had specifically about aspirin itself and the
yeah,
safety
so
of it.
aspirin has become actually recommended, not high dose, but 81 milligram aspirin, or 162 at times. And again, that should be, if you've had a tear or dissection, that should be discussed with the vascular doctors and the OB, but really highly recommended in this type of scenario. So very important. And again, there's some hesitation with things like blood pressures, but when you look at the actual data and when you look at the outcomes of our patients, it's much, much better using the medications without significant fetal risk, as long as the baby's being monitored. So setting up this team, you have maternal and fetal monitoring, right? You have all of the doctors talking, you have coordinated care, and it changes the outcomes, and it changes the comfort level of the patient for good reasons, because they should be more comfortable, right? So you know if you should be more comfortable or not. So I think awareness and having your eyes open in this is actually really, really important. And then there's a lot of considerations during labor and delivery that can make a difference, especially with connective tissue disease issues. So things like pain management, the modes of analgesia, like do you get an epidural or general anesthesia? Does it actually make a difference for certain people? If you have a significant scoliosis, that may affect the opportunity to even have an epidural, right?
Wow,
So
yeah.
it can be very, very important to have these discussions ahead of time and to understand. Also, if you have a significant aneurysm, is it really different to do vaginal versus cesarean section? And the answer to that is also nebulous, because in certain centers, the maternal fetal medicine doctors may be very, very comfortable and have a lot of experience and good outcomes with what's called passive second stage delivery, which is forceps or vacuum. And those can really only be done above 32 weeks because the head of the child has to be strong enough not to get hurt by that type of delivery. But you can have, a passive second stage of delivery versus a cesarean section for maternal reasons to lower the wall stress. So there are certain scenarios where a cesarean section really is safer, and certain scenarios where a vaginal delivery can be safer. And certainly the recovery from a vaginal delivery is going to be much faster and shorter than a whole surgery. So,
sorry, I was just going to say, so there was actually some other, Diana, wasn't there some questions there about birthing center?
Yeah, there was some question about the safety of delivering in a birthing center, and if something were to go wrong, the travel time between the birthing center and trauma center hospital.
Yeah, something about like not maybe if they even know about the aortic disease or an aneurysm, like maybe they still don't want to be overly cautious, but still be within a few minutes or something.
Yeah, I mean, usually if someone has had, for example, a prior dissection or has a larger aneurysm, I think that having them in a center where you actually have a cardiothoracic surgeon available would be a really smart idea, and where they have the imaging immediately available, and where they're aware of the issues that someone is already going through. So if you already know that you have that disease, you have surveillance, you do know kind of where you are in the risk and what's been happening through the pregnancy. So high-risk patients, really are generally referred to quaternary care centers where they have somebody available 24/7. If you don't know that you have disease, right, and all of a sudden you find out you have disease in the middle of pregnancy or delivery, then there is travel time, and there's a lot of variability in regional care, access to emergency surgery, because again, at the time of a dissection, there's a very high mortality, and that mortality is cut short by getting into surgery quickly. So not only the time to travel somewhere, but the time to diagnose, the availability of CT and MR quickly, and the availability of cardiothoracic surgery, because not all centers have cardiothoracic surgeons standing there.
Right.
So,
which I can attest to. I was at 3 different hospitals, and they said we take care of cardiac care. And I'm thinking, just because it says it on the side of the building doesn't actually mean that they are capable even of dealing with that kind of case.
Right.
Yeah. So I think part of your preconceptual counseling is, is it reasonable for me to be in a birthing center or have a birth at home versus with my health or risk? Do I need to be, under special care? And can I be seen by a general obstetrician, or do I need the high-risk obstetrician? Right.
So would that be an option, like those questions, would that be for any case, whether, I know we had one patient question about SCAD. I think they had a coronary aneurysm. So would those guidelines be for anybody who has the potential for SCAD, I guess, with the coronary or aortic disease, with an aneurysm, connective tissue disorder, like all of the above?
Right, so SCAD is kind of a whole different ballpark. So SCAD is dissection of coronary arteries, separate from aortic dissection.
Yeah.
And it really is a different disease, and SCAD, often will happen during pregnancy as a first scenario. So they've never had anything during pregnancy. With the increased workload of the pregnancy, the increased arterial wall stress, you can have SCAD. And SCAD genetically is linked to something called fibromuscular dysplasia that can affect the medium and smaller sized vessels. If somebody has chest pain, concerning for a heart attack, that's the kind of symptoms that somebody with SCAD has, and they frankly can have and often do have heart attack at their presentation. So different presentation than aortic dissection, often treated medically, often heals, but a high recurrence rate. And it's very important to figure out, how well have you healed? What is your heart function from the heart attack that occurred? So there's a lot of different questions with SCAD than there are with aortic dissection. I really would make those two different diseases.
Okay.
But both very common and concerning in pregnancy. Those are high risk scenarios where you certainly would want to be, if you're pregnant and you've had a history of SCAD, or you have fibromuscular dysplasia or lupus, where we're worried about a higher increase of SCAD or higher incidence, then you really are going to want to deliver in a care center where they have cardiac care immediately available.
And I believe we had a question, speaking of things that are outside the aortic dissection, about valves, leaking valves of the heart as well. So is that an entirely separate discussion as well, or is that still run with the high risk?
So again, it depends. Are you talking about a leaky aortic valve because of the aortic aneurysm or dissection or rheumatic heart disease? So there's a whole world of vascular heart disease.
I think all it said was aortic and leaky. So I think we didn't really have much more than that, right, Diana?
To go on, right. Yeah, it was just talking about one of the valves was leaking in their heart. And
so in this scenario, when we're talking about aortic dissection or aneurysm, sometimes an aneurysm can actually stretch the annulus of the aortic valve. So you have a stretched open valve where the leaflets just can't touch, and blood goes back and forth through the area that can't coapt well. So you get a leaking valve, and then you have all this extra volume of pregnancy, and it is a very high pressure on the heart. Generally, young, healthy people tolerate that for a good period of time. If the heart is dilating or becoming dysfunctional, then it becomes more of an urgency or emergency, where sometimes you actually have to do things like heart surgery during a pregnancy. And there is a high risk of fetal loss during early heart surgery during pregnancy. Certainly we can get away with it here and there, but it's scary, and there is a high risk of fetal loss. So if you have something like a severely leaky valve and you're looking to have a pregnancy, or you have an enlarging aneurysm and you're looking to have a pregnancy, that is something you really could get fixed first, and then have a safe, wonderful experience during pregnancy rather than having a terrifying, risky experience. So that's, again, why the preconceptual counseling can matter so much, because if it's a very mildly leaky valve, it may go up to moderately leaky during the pregnancy, and that should be pretty well tolerated. Versus if it's a severely leaky valve, and a significant aneurysm, and that gets a little bit worse, that can tip someone over into florid heart failure, poor perfusion, true emergencies during pregnancy. So that's why I strongly encourage the early discussions and evaluation, because the leaky valve in an aortic aneurysm or dissection is secondary to the primary problem, right? And it's a symptom of it, and it's usually a symptom that it's not being tolerated well.
Wow.
right.
Diana, do you have any other question for her to follow up with that? Or separately, maybe the
No, I
CTDs?
think that's it for now. I mean, just trying to keep in mind some of the questions that we had run across while we were doing our research, but let's keep the
Well,
discussion going, and then we can come up with.
Yeah, so one thing that I don't want to miss discussing is breastfeeding. And
Yeah.
I heard as we were talking before this time that you had a wonderful maternal fetal medicine discussion about this. But it is really important that in the studies so far, or just the databases so far of people with aortic dilation, not dissection, maybe or maybe not aneurysm, but aortic level above normal. They actually have found more issues with increased enlargement or dissection or rupture, more with breastfeeding than even during the pregnancy itself. And it hasn't been clear why lactation would have a role in breastfeeding. I mean, in aortic dilation. There are a lot of thoughts that maybe a particular hormone that has to do with lactation might actually contribute to weakening the wall strength. Theoretically, that may be the issue, or maybe certain hormones kind of unroof the weakness in the wall from underlying genetic changes. But during breastfeeding, the changes are typically not drastic, but they could increase the risk in somebody that's predisposed. So we don't have a perfect recommendation for what to do during lactation. That again should be a personalized discussion. But because there's a potential for aortic enlargement, it's actually really important to have that discussion. A lot of my patients will have, monitored a little closer during breastfeeding. Maybe keep breastfeeding to the first 3 months where you're really getting the immune therapies transferred to the child, because there's so many benefits both for the mom and the child of breastfeeding. But at the same time, limiting it to the really primary important parts.
yeah. It's so crazy that you talk about just the breastfeeding specifically, because that is actually the moment that I dissected. I was nursing at the time of my pain. And, I had to kind of put her down between on my lap, on the gurney that I was on in the hospital. But I was always so, again, I also believe that it's so important to be able to do that. And some women really want that extra bonding that goes with it as well. But I didn't want to deter from anyone making that decision to or not to, based on, at the time, not really having much evidence out there. And again, I know, people have been working on this, but I guess your point would be also, if you know of having aortic disease or know of a family history, then I guess it would be even more prudent to be asking those questions in your genetic counseling sessions.
Yeah, and also maybe not in the genetic counseling sessions, but with your maternal fetal medicine doctor and your cardiac or vascular doctor.
Okay.
That's monitoring your aorta during the pregnancy, right? So you need someone monitoring your aorta during the pregnancy and postpartum. So if you're breastfeeding, you may want to get monitored more closely. Is the aneurysm changing? And if you have discomfort, which sometimes there are false calls, right? You have discomfort because you have breast pain. You have discomfort because you have a milk cyst. We would much rather you get an evaluation than ignore something that could be a dissection or aneurysm increase in size and, potential rupture.
Well, and what about somebody who also is wanting to take that risk and go ahead and breastfeed, is going to be monitored more closely? What about medications during that time period? Or, you said like prior, there's certain medications that are safe to take. What are your thoughts for after delivery and while you're breastfeeding?
So after delivery, the question is a little different. It's not placental and blood transfer. It's do these medicines get into the milk? Right. And there are some differences in which ones actually get into the milk in significant concentrations. Most of the medicines have been tested in breast milk, so we have a good understanding of whether they get in a concentrated way where the baby could get even too much because it's concentrated compared to what it is for the mom, or where the baby gets almost nothing. And sometimes either the medications shouldn't be given or restricted in dose. So it's a really important question to have that discussion. And then certain medicines that are really not okay in pregnancy are actually fine in breastfeeding because they don't really get into the breast milk, or they're safe for the baby at that age and now that the baby's organs are formed. So it's actually really important to have that conversation about what do you need for your blood pressure control? Are you breastfeeding? Are there medicines that you really have to have that are not safe for breastfeeding, where you shouldn't breastfeed and you should take the medications? Also, you know, with breastfeeding, you need a lot of hydration and nutritional support. So are you able to get that in and maintain what you need for yourself plus the breastfeeding? So it's important to make sure that your body is able to handle that and that you're actually able to intake what you need to intake to take care of both. So all of those, you know, all of those conversations are really important. And it can be an amazing and wonderful experience. So we try to give everybody the opportunity to have that experience if it's safe and reasonable for you to do. But you also, you know, haven't failed if you can't do it. If you can't do it, the alternatives currently are outstanding. You can have donated breast milk, or the formulas are actually very, very good. So if you can't do it, you know, you can still do everything around it, and still certainly have bonding experience.
Yeah.
Yeah.
While we talk about the breastfeeding and the stress on the body, if you have an aortic issue beforehand, you've made it through the birth by the grace of God and everything's good, what is the difference of strain on the body between breastfeeding from the breast and pumping so that your baby gets all the nutrients from the breast milk, but maybe doesn't go through all that extra? Is there extra strain having the baby take the breast milk straight from the breast versus pumping and then a bottle?
Yeah, so great question, and probably no difference.
Okay.
Right, because it's still lactation, it's still the oxytocin release, which we think may be related to the aortic changes if they happen. It's the hormone changes and the process and the making the milk.
That's the stress, not the delivery.
It's not
system.
the delivery, right?
I just know that when I had my open heart surgery within a couple hours of my first pain, because it was in type 1 and 2 A and B dissection. And then the hospital in the cardiovascular ICU unit brought up pumping equipment for me because I just had my baby and I wanted to keep breast milk going. But I know that me pumping, especially in those first couple weeks after, did not get as much as I would have had she gone straight to the breast. And that's why I thought maybe there would be a difference.
Right, but honestly, it's probably not whether she went to the breast or whether you were pumping, but the shock that you have during a dissection, the low flow, the low pressures, and then all of the anesthetics, pain medications. So first of all, you know, you don't want to actually give her that milk.
Right.
So you're
I
going to
dumped
throw out
for
the
a
milk
while.
from the anesthesia and all of the drugs that are required, you know, the paralytics, the, you know, the medications that you certainly wouldn't want her to have. So you're going to throw it out, but you need to keep it going. So from shock, if somebody really has shock, low blood pressures, low perfusion, all of the, you know, all of the stress response, a lot of times the milk production just stops. So the trying to pump around the surgery is trying to help you continue to make the milk. And if they can keep it going, then you'll keep it going. But if it ends, then you can't really get it restarted.
So what's the time frame that you want to keep trying?
So if you want to keep trying, they keep trying as soon as you're hemodynamically stable, like you have enough blood pressure to support yourself. You know, they'll try to continue the milk production if that's what you want to do, by pumping. right? And then they'll throw out the milk because of all the drugs in the milk. But the goal is to try to keep you producing milk so that you'll be able to feed as soon as you're off of the medications that you can't share. So the goal there was to keep you producing milk to meet your goals.
Right.
Yeah, but I don't
Yes,
think you can say that there was a difference between feeding and pumping, because again, you're talking about somebody coming out of shock with all these medications delivered and just trying to keep it going and trying to recover that part of things and have that left as something that you continue.
Right. Yeah, I just wanted to go on pumping so that my body would still continue to produce the milk.
Yeah.
But we dumped it all, of course, because of the meds. I just always, I guess, assumed that it was the pump versus the baby suction that was the difference. It didn't even occur to me that it was the shock to the body of, a C-section, a tubal, and open heart surgery within a few
There's a lot
days
going on.
that did it.
But that makes more sense, right?
Yeah. Well, and I
and
do want
again,
to say
the first
2
thing
years later.
right, so the first thing you did, which I think we have to address, is you blamed yourself
Yeah.
instead of
Well,
blaming
I just
the
blamed
condition,
the
which I think is really important to acknowledge here, because again, this is a disease that creeps up and sneaks in on people that are healthy, beautiful young people. You didn't do anything wrong. You weren't living an unhealthy lifestyle. You didn't even know you had something. And this happens. And again, it's very important to talk about, well, how do I get the best possible result for both of us? Right? And thankfully, you both had beautiful, healthy children. And sometimes when this happens before delivery, it's not always the case that everybody survives. So, you have beautiful, healthy children and you want to continue to feed them, and usually you can, but there's probably someone on this that couldn't. And that's okay, because again, the goal is that we have two lives, and that you have this incredible bonding because you both survived, and that also you're looking to protect the children down the line of how do we have them have a future where they don't have to deal with aortic disease. So that's where it comes in for genetic testing, not just for you, but also for the child, so that if there is, the ability later to do something like egg screening or embryo screening, that you can make a choice if that's within your goals and if that's within your belief system where you'd like to do that, because it's available now.
Yeah.
Yeah, and hopefully the gene testing's getting better and better, where we'll actually find more things that we understand better. Because I think it's still good, but limited testing where we don't pick everybody up.
I think there was one
we got
question
to,
about
test
that.
everybody.
With I think somebody was trying to conceive and wanted to know about having the option for an early pregnancy testing for LDS, but what is the risk of miscarriage? And they were like looking for any statistics regarding, of course, that was specifically for Louis-Dietz syndrome.
Yeah, so
I think
there's a difference of whether you're testing before pregnancy or during pregnancy. Yeah, so I think the question you're asking is somebody that may be already pregnant and they're offering genetic testing like chorionic villus testing or amniocentesis.
That was my thought, was they were talking about an amniocentesis because I remember being tested when the scans didn't come up great when I was pregnant, before, long before the dissection, but they ended up having to do an amniocentesis in order for us to make, a decision with the baby. And that's what I thought of with this question is, that risk of miscarriage when you're doing the amnio.
Yeah, like pros and cons.
Yeah. So I think at the time of a procedure, depending on, if you're doing the very early testing or the amnio, it also depends on the timing of the testing. And again, part of what you're doing is saying, what would I do if the testing is abnormal? So if the testing's abnormal, but you're not going to do anything but look, then you could just continue to do the non-invasive surveillance and look.
Mm-hmm.
Right? And part of what you're looking for in prenatal screening is, you know, what do you need for the baby for delivery? So, for example, if there's a cardiac defect, that is a different outcome if the baby's delivered where there's a pediatric heart surgeon. That may change where you deliver, what your delivery team is, you know, when you deliver, the mode of delivery, all around fetal issues. So the screening actually matters a ton. You know, if you're talking about early diagnosis of a genetic issue that you're not going to change the care of, and there may be a little bit of increased risk, then you may just want to wait till you meet your person and test then.
Mm-hmm.
So these are, again, personal decisions where you're asking what is the risk at the time and what would I do with the decision. And, you know, I encourage people to have their partner or family or support systems involved in that decision and testing, because they're all going to be part of it if there is a problem.
Okay. I'm looking at the other questions, Diana. I don't know if you have any other ones that we can jump to. I know we're quickly approaching our hour. If you're good, I think the conversation is great. If you ladies are able to continue going just a little bit, not too long. Doc, what do you
I
think?
do think that we have to take a minute though, because there's, you know, there's a lot of, you know, there's a lot of sadness in this in a lot of ways, but there are a lot of people who do extraordinarily well. The care has gotten better. The access to care has gotten better. The recognition of the disease is emerging and getting better. And the screening has gotten much better. So between echo, CT scans, MRI scans, transesophageal echoes, the diagnostic abilities have gotten better. And I think it's really important to advocate, to have a team, to have these discussions and understand the risk. But we have a lot of moms that are doing extremely well with thoughtful decisions, including the two of you. So I do think we need to celebrate that. And again, we're trying to be smarter, eyes open, well aware, and make these personal decisions with the support system that you have, and to the best of your ability. And also to be there for the kids that you may already have. So these are big decisions, and they should be made with support and with, you know, with people that care about you and people that you trust.
Well, I appreciate you putting that input in, because I know a lot of women in the group really do struggle, no matter what category, you know, pre, post they're in, whether, you know, the stresses during gestation and being worried during the pregnancy, or how to care for their baby afterwards. Like, can I lift my 10-pound baby? You know, that, and which is another topic to touch too, because not, you know, the pregnancy, or I mean, the breastfeeding that you mentioned too, a lot of us, you know, I know myself was so worried about, I'm not going to connect with my baby. We're not going to be able to bond. And I was just so preoccupied with, one, not seeing her for a week, then not being able to breastfeed, and then for like a month not being able to really care for her because I was just sleeping and recovering the whole time. But just to note that, like you said, with the care, there is so much hope. And then with stories, you know, like Diana's and I, that, you know, in hindsight, we see that, you know, we were fine. We bonded with our babies, like things were stable, and we're still here 10 years later. And, you know, things are getting better, but that's also attesting to all the work that you and other providers do, and the research, and then, you know, all of us sharing our stories so that the next ones can have a better time of it.
Right, and also so that someone will recognize the symptoms early, get in there and live, right? Because you got to get in there to live. And a lot of the deaths are people that don't go in. I'm young and healthy. I'll get through this. I'm just going to suck it up, which is, you know, in this disease, the absolute wrong approach.
Right.
Yeah.
I remember after we
Yeah.
did that first aortic dissection awareness video, with Dr. Melissa Russo and Baylor Hospital, one thing that was kind of difficult for me is when I tried to send it to the hospitals in the area, because I think it's important. A lot of people, when they're in medical school, the nurses, the doctors, they touch on aortic dissection, but a lot of them have never seen a survivor or spoken to a survivor before. And then I tried to send out this video to everybody to just spread awareness and let it go. And a lot of them said, well, it's a YouTube link, so we can't send it to anybody. We can't open it. So how do we get that message out when we've got all the information there, but because of information technology, they won't open it?
Well, I think you guys are doing a phenomenal job. And if you look at the viewership you have with Aortic Hope, I mean, when Aortic Hope started, it was pretty much what, 3 women?
Mm-hmm.
And
Yeah.
and they are very impassioned, wonderful advocates who have changed the world. And the work you're doing is absolutely incredible. The viewership that you have speaks worlds, right? And just having this conversation, a conversation about pregnancy and aortic disease, instead of just saying no, right? Which
Mm-hmm.
which is the easy answer. And recognizing the risk, dealing with the risk, coming up with a personal plan, coming up with a family plan, having the frank discussions, keeping eyes open, getting the care, getting the fetal care. It's better outcomes, and it's really important to have these discussions.
Well, also talking about or thinking about post, delivery and such. Can you touch on, I know a lot of times even for exercise, people have a lot of questions regarding exercise. How much can I lift? What activities can I do? I know the women in the group have always had questions about just caring for their newborn. They survived this, and I had a really tiny baby, so I didn't worry about the weight so much because she was just so itty bitty. But some other people are like worried, like they need to make an encampment on their floor, that they can't lift their kid at all. Like I have to do everything on the floor, and my husband goes to work, and like, what can I do? Can you guide them or encourage them on what it is that is okay for them during that time period?
Yes, so absolutely. And again, in this group, there's a lot of variability, but the first thing that really matters is after giving birth, we do not like people to be perfectly sedentary because there's a risk of blood clots. And there's also a need to condition, and there's a need for the tissues to regain their strength and elasticity. So walking is really important. Walking and just kind of light aerobic activity. Incredibly important. So if you're exhausted, walk, then rest, then walk, then rest, but do not just stay in bed. That's the absolute worst thing to do. With people who have increasing aortic aneurysms, significant aneurysms, or dissections, there's a lot of variability in recommendations on exactly how many pounds to lift. But somewhere between 35 and 50 pounds is usually the range of the recommendation. Part of that depends on your strength, your muscle strength, your body size, how it's distributed. But 35 to 50 pounds, I think, is a reasonable recommendation. Immediately after a sternotomy incision, generally the recommendation is about 10 pounds. And that would be for the first 1 to 3 months. And part of that depends on the stability of the sternum, how well is the healing, how far out are you, how complete was the repair. Those are the big things. And also just making sure the sternum heals and that the wound doesn't get infected. So very important for, where the baby's positioned, etc. But generally, 10 pounds is never going to be an issue. You can always hold, and holding things in and not pulling on the incision is going to be fine. So whether you are comfortable carrying the baby may also include if you're on pain medications, a lot of new blood pressure medicines. If you're lightheaded or dizzy, you don't want to carry a newborn. but you could sit down and have somebody put the newborn on your lap, right? Snuggle with the newborn, nap with the newborn, you know, and
There's adaptations.
adaptations,
Yeah,
right? And you have
absolutely.
usually, you know, after something like a dissection, you're going to have more family around to make sure that both of you are safe. So definitely adaptations are really important. And an encampment can be really nice for both of you. But can you pick up the baby and, you know, walk around the house or walk around the neighborhood? As long as you're not lightheaded or dizzy, absolutely. Right now, if you have a 50-pound baby, because this happened a year out, then you're going to want a stroller. You're going to want someone to help you get the 2-year-old or the child from the car into the stroller and back. So that's a different scenario where you really do need to watch the weight. And also that child may kick a lot. And you need to allow healing. So if you don't allow healing, you can have a big setback. So you do have to be thoughtful in your approach. It also depends on the temperament of the child.
Well, I like how you're talking about the adaptations too. I know my husband and I did that with our we had a 15-month-old at the time, and then I dissected with the second one. So trying to teach them early how to buckle themselves in, so I'm not having to lean over or pick them up from a weird position that would cause. I had like these weird pains on my stomach. And, you know, so there are adaptations that you can do, or when they get older, like you said, the stroller. And, you know, if you have family or friends around that can help you even push them. I mean, I tried to start getting back to exercise, but the social run club that I was a part of, everybody else helped to push my kids in the stroller because I was concerned about the weight. You know, but it's nice to hear how that's evolving as well with exercise and with pregnancy, because people are coming to know more that there is more that you can do. You know, there's like the weight isn't going to be like you can't lift 10 pounds. I think that has kind of changed overall, and there's a more consistent, I think, advice around those things.
I think so too. And also, you know, what you pointed out is exactly right, that it was the 15-month-old's care that was so hard with the restrictions and the healing that you needed to do, where the neonate's care, it was actually more straightforward and you could do it.
Yeah.
Right. And I think that's the experience that most people have, that it's the older kids that are the hardest because they do way more. They're more active. They're moving, kicking, you know, may not be ready to do the help that you need. And that's where you actually need a lot more help. Yeah.
I had a 2-year-old and then my newborn when I had surgery as well. Like Carmen and I are spirit sisters.
Yeah, you really are.
Yeah.
And it's wonderful that you guys met. You know,
Well,
and
you know, so we met because I was trying to start this video for awareness for pregnancy. I wanted it to be around aortic disease in general, talk about aneurysms, dissections, but then jump into why it happens in pregnancy or how this could happen and the things that go along with that. And so I asked her to I forget how we met originally online, but I asked her to come to Texas. And so she stayed here and we did this video. And then the hospital, so I was actually trying to raise money to do it because, you know, media people that I had questioned wanted like $3,000 to do this video. And I'm like, I don't think I can do that. But I was going to try to press forward creating this run event that I do called Run for Aortic Health and pay for it via this event. But then Baylor Hospital here in Dallas Fort Worth took the video on pro bono, and that's how the money from the event started going to, you know, the John Ritter Research Program and other research initiatives. And now we're at that we just finished our 8th year with the event and have given like $150,000 from that little event, which I know is not a gala. A gala can probably raise that amount quickly, but you know, we were pretty proud of it. And so Diana was here for that first one, and we could share our stories with other people from that video and still today.
It was
Yeah,
actually
and
his
also the
website.
connections and support that, that is here is part of what Aortic Hope's about. And I think it's incredibly important to have that. And also it helps people make decisions about their own level of risk, what they're willing to do. But for you guys, it wasn't decisions about your level of risk, right? You didn't know you had this.
Right.
And again, it was getting help quickly, recognizing the symptoms, finding care, and getting to care where they could get you in quickly. So understanding that this is a possibility is important because some people during pregnancy really feel infallible, right? And it's very hard to recognize that something is actually wrong.
Yeah.
And discriminating even as a provider is very hard because, to be honest, third trimester pregnancy looks like heart failure. You can't breathe, you're full of fluid, your ankles are swollen. There's a third heart sound that the only times that it's normal is during heart failure or with the third trimester of pregnancy, because everything is relaxed as far as the vessel walls, the heart, the hormones are very powerful. So you have changes that are confusing to both the patient and the providers, and that's why some of the objective testing is incredibly important. And you can't tell and we can't tell, so we get the objective testing. And you have to insist on the testing. And if the testing is normal, then you actually are okay.
Yeah.
Yeah.
Diana, did you have another input to what she was going to say? Otherwise, I was going to jump to one more little topic that we had.
I was just going to say, when this first happened, I had a 2-year-old, and what I had to do was kind of teach him that I would hold him as much as he wanted me to. I just couldn't do it while I was standing up. So I would sit down, have him sit next to me and hold him that way, or sit on the ground with him, things like that. Just for anybody listening who's struggling with it. And then my newborn, since I could only lift a gallon of milk, the doctors had said after my sternum was healing. And then 3 months after my open heart, I had an open abdominal aortic repair. So I had a lot of caution with my front self. What I would do with my daughter when she was still around 10 pounds, I couldn't lift her and the baby carrier at the same time. It was too much. So I would push the stroller up, and then I would set her down and aside, then put the car seat in the car, then put her in it instead of doing both at one time. So talking about adaptations, for those listening of those with littles, there are things you can do to still show love, to still, get stuff done. It just might have to be done in parts. And realizing that laundry does not have to get done right away.
Thank
It
you.
is possible. Leave it sitting. And one of the other major things for me personally to get over, besides the mourning my life lost, because I was a very active person beforehand, was asking for help. That was a big, big hurdle for me.
Yeah. Well, I know there's so many questions around all of it. I mean, these women are really, and that's one thing with this group that we hope that we are able to help somebody, whatever stage it is that they're on their journey. But that's another question, a topic I have too, as far as stages, because you mentioned about the hormones. That was one of the last, I think, kind of topics aside from everything else that we covered was hormone therapy. And really, I'm asking this because I'm asking this. Because, but I know there have to be other people out there who are probably thinking the same things. So when I first dissected, there was question about not utilizing any hormone therapy for contraception. So was given the option to do like a copper IUD, and did that prior to doing a tubal ligation, since they said don't get pregnant again. And I took that very seriously, and I was scared. So I did that within a year. But my question was then at the time was, well, what about when the time I get to like perimenopause, menopause stage, what is that going to look like? And I'm kind of there, like starting, I think. Don't really have a ton of the symptoms yet, but I know it's coming very quickly as I'm approaching my mid 40s. And so I didn't know what the safety is around hormone replacement therapy, whether it's estrogen, testosterone, or whatever it is that somebody might be needing. And does it depend on the kind of case? Is it a case by case basis that somebody would be ill-advised to do it, or that it's okay?
So I mean, I think there's a huge concern, and I don't think that we have the full story yet. And we've gone kind of back and forth on the safety of hormone replacement in general. And a lot of that is because of the risk of estrogen. And again, this is not fully established, but there is concern that estrogen can exacerbate aortic disease progression because of the way it dilates and relaxes the arterial wall. So, you know, it's really the estrogen that's the concern. So if you have a uterus, then you're talking about hormone replacement therapy in menopause with estrogen and progesterone as a combination hormone of some sort. And the progestins can increase the blood pressure. So watching the blood pressure can be done. You could take blood pressure medications or increase blood pressure medications. So that can carefully be considered and monitored. But the risk of the estrogen exacerbating the vascular abnormalities, especially in someone who's already dissected or has a genetic predisposition, we think that there really is an increased risk, and we generally do try to stay away from them. And that I hate to say, because a lot of people have very significant changes and difficulties around menopause. So the alternative therapies are there. They're not quite as effective as hormonal-based therapies, but things like SSRIs for hot flashes, gabapentin for night sweats, which is more of it affects the nerves more than anything, but it can affect the night sweats. Things like vaginal moisturizers or lubricants for dryness. Being on top of bone health medications matters a ton, but the hormone therapy directly is, really is at this point fairly contraindicated for someone who's had a dissection. Okay. Now, is that true for somebody who's had an aneurysm? I think it depends on the underlying reason. So if you're hypertensive, if you have vascular disease, we do try to avoid HRT.
Okay. And that includes like even testosterone. I think that there was talk about like that could increase your blood pressure or something.
Yeah, so it can increase the blood pressure, and it is converted to some extent over to estrogen. So part of the goal of increasing the testosterone is this transformation to the estrogens as well. But again, the testosterone also has the clotting effects, even maybe more so the clotting effect, and the changes of the arterial wall and blood pressure.
So who would you advise the patients to talk to about that? I know myself, the cardiovascular seemed really hesitant to give an answer, and they pinged it off to OB, and then the OB kind of pinged it. So like we're doing this ping pong and nobody's really answering the question. So therefore, I'm like, you're kind of stuck in this limbo, like somebody please give me an answer to what is safe or not safe so that I can treat whatever symptom it is that I'm feeling,
Yeah, so I think the OB is or the GYN at that point is gonna be the primary driver of the decision and the prescription for HRT. But I do think that the cardiovascular expert is really going to weigh in on what is the risk and trying to help you balance what is your risk and the risks and benefits of an estrogen-based therapy, whether it's estrogen, testosterone, progesterone, or just, estrogen. Now, a lot of people feel differently about things like the topical estrogens. So things like just the vaginal creams, do you really absorb very much of them? What is the dose range? You know, could you do very low dose? Can you do topical? So some people will do a hormone-coated IUD for the topical effects if they're having irregular bleeding or spotting, even though they're not necessarily using it at that point for birth control. You could use it to regulate these cycles and to minimize the symptoms. So there is a lot that can be done. And again, things like IUDs and somebody who has Marfan's or Loeys Dietz may have higher risk because the tissues are thinner. So, or especially with, for example, vascular or Ehlers-Danlos, the tissues may be thinner. So
like ill indicated for them to use that as a contraception.
Depending on what they really have.
Yeah. Okay.
Right. Yeah. So I think that that's why the individual discussions are so important.
Well, thank you for all that. I think we've talked about so many topics. This has been fantastic.
Right? You can't do that.
Yeah.
It's fine, take it, or it's fine, do it is not the right answer, and an absolute no is not the right answer. If that's what you're getting, you're probably talking to, you know, someone that isn't comfortable with the situation. And you want to have the full conversation and understand what do you actually have, what are your actual risks, and then you want to make a risk-benefit analysis for you. And you want to do it thoughtfully with eyes open because you can get into some trouble.
Thank you.
Yeah.
Diana, do you have, we've covered most everything, I think. Do you have any extra questions, or should we ask Josh if there's any?
Yeah. Oh boy, a lot of information today.
It's a lot. These are a lot of big topics. We could have an hour on any one of them.
Right.
And I do want to say that I loved meeting both of you, and you are inspirational to me, and definitely seeing both of you thrive and raise healthy children, you know, makes it easy to keep going. So.
Thank you.
Thank you.
Well, Josh, do we have anything online?
Yeah, if I could just jump in before we close out. I want to say hi to a bunch of people that jumped in. Velda, Tom, LM Sanchez, Michael Smith, Molly. We have a new viewer, PR Cosmos. This person says, I had no prior knowledge and dissected at week 25.
That is a tough time to have a dissection, a really tough time. The risks are high. The risks to the baby are high.
So make sure that you're following your care closely, and make sure you have a team in place like Dr. Fisher was explaining early on.
Yeah.
And that you're at a center where they're comfortable and can help you properly.
And they go on to say, yes, definitely. This is such a great conversation. It's answering a lot of what ifs that I never had answers for. Right. Good. And so, you know, as I do these things, this is one of the things that I'm so excited about. It's the idea that, you know, we have two survivors of something that, you know, that's already crazy. There's a baby involved.
Two babies here.
Two babies involved. Well, here, yeah. And then, you know, it never even occurred to me until, you know, a third of the way into the show when you were like, and then if it's your second child, and I'm like, oh my goodness. And Diana's like, I had a 2-year-old, terrible twos, and this has to go down. That's incredible.
Yeah, that's why this group is just, we try to keep the pregnancy group and postpartum group pretty tight, you know, entering, because it is such a small niche group. And it's also like a lot, you know, obviously with all these topics, it's a very intimate conversation. And sometimes even when you're just having these conversations with your own physician, it can be a little difficult, or maybe you're not as assertive to ask certain questions, or you just don't know what to ask maybe. So that's where, you know, these kinds of things come into play, or joining the Aortic what do we call it now? Pregnancy and aortic disease. I'm sorry, guys, I forget what we title it. Pregnancy and postpartum and aortic disease, but you can search it pretty easily just putting aortic dissection in there. And of course, Aortic Hope has, our link as well. But it's just a place for this small group to be able to ping ideas off of each other about their experiences or gain insight on questions like what we've covered today. So,
yeah.
Now,
And also, remembering that even if you make a decision, you may have to adjust based on what your body's doing in response to the challenges of pregnancy. So the 20, we just heard 25 weeks, but 28 to 30 weeks is really when the body has the biggest, is tolerating the biggest volume change. That's where you really are holding the full body volume, the full blood volume that you're going to be handling. And then after about 30 to 32 weeks, the baby grows about a half pound a week, but you've already been handling the full workload. So a lot of times where you see the issues is right around 28 to 30 weeks as you're getting to this peak work that the body has to do.
Yeah. And then I hear also postpartum going along those lines. So, but after you deliver, I guess that whole extra output is then just kind of dumped back into your system, and just kind of overloads the mom in the postpartum period, correct?
Correct. Although generally there is blood loss during the delivery or whether it's C-section or vaginal that offsets that some.
Oh,
but there is a huge return.
yeah. Okay.
Plus the breastfeeding on top of it.
Yeah. Plus breastfeeding.
Yeah, but that comes a little bit, it's slow and later. So if you think about it, it's a couple of ounces to start with. So I don't think the fluid that you lose in the first few days after,
Not
after
the fluid, just your
delivery is
body, your body preparing.
Yeah.
Oh,
Well,
in
your body
general.
starts preparing though all the way, all the way through.
Yeah.
Yeah.
wow. Josh, what else we got out there?
I wanted to clarify the website that you wanted us to take a look at as well.
For the pregnancy video?
Well, the pregnancy video, that would be great. I would like to be able to link to that. But the Registry of Centers of Excellence, where did you?
Oh, so I was talking about the Adult Congenital Heart Association, or ACHA, and they have a travel directory for adult congenital heart programs. And that is really adult congenital heart disease means people that have cardiac defects that have survived pediatric cardiology care and are now adults having adult care. So there are, as far as care providers for cardio OB, there's a whole new field of cardio OB care providers. But adult congenital heart doctors have done cardiac OB issues always, because our patients are now becoming adults, and pregnancy is a common question and condition that we've always dealt with. So the newer field is providers that are specializing in the OB heart issues that arise, whether it's heart muscle or heart rhythm or aortic disease. There are a couple of groups of people that have special training now to actually address these questions in a better fashion, and also to coordinate research.
Mm-hmm. Well, I'll get with you, Dr. Fisher, and we can get that. Maybe we can get some kind of link, and we can have Josh add it to the video along with the pregnancy awareness video that we did back in 2017, because still a lot of it's relevant today. Yeah.
I just sent you the link, Josh, on email to the pregnancy video.
Oh,
I've
let
got
me
that
take a look.
in a shortcut. I like to send it to anybody who wants to see it.
Yeah, thank you. And we'll put this as part of we have a playlist for when we have aortic, I don't want to say the word patients, but people in the community, if they do anything, we put this in a little playlist so that it's like everybody that we talk to can go into a playlist and see where other touch points are. Mm-hmm.
So
Awesome.
the travel directory is achaheart.org. And then Oh, good, good, good.
Yeah,
Okay.
yeah, I put it
Awesome.
in the chat. That one was easy. I just couldn't, like, it
Uh,
was going
Thank
so
you.
fast earlier and I didn't want to stop you.
Well, do we have anything else out there, Josh, or was that
No,
the last
mostly
one?
it's just that and some amazement, some hearts and stuff. Hi,
Okay,
Carmen. Hi, Dr.
awesome.
Fisher. Thank you so very much for being here for us. Thank you,
Thank you.
Molly. Yeah, lots of
Awesome.
hellos and just chit chat.
Okay, well, awesome. Well, thank you so much. I think that probably wraps us up. Thank you so much for staying on longer with us, because a lot of times these videos, if you cut them short, it's just you don't quite get all the information that you want. And I think this turned out fantastic. So thank you for staying on a little bit longer. For all of our people in the aortic community, thank you for being here, Dr. Fisher, Diana.
You're
And
welcome.
hope
Good
Carmen, for
night.
putting all this together and the website and everything you do.
Oh, thank you. Well, hopefully we'll have another video shortly. I don't know when, but Diana, I will be seeing, actually, my
Yes,
daughter plays travel ice hockey, and her tournament is just where Diana lives. So I'm going to
yep.
see her in 3 weeks. And so
My son
maybe
plays
we'll do a
hockey
little
too.
short live from Diana's house.
Yeah, yeah,
That's fun.
yes.
So, so stay tuned until then. So thank you again, guys, so much for joining us, and we'll see you the next time.
All right. Thank you all.
Bye.
Bye.